very briefly introduce Dr. Ilene Wong Gregorio, who is a practicing surgeon by day, masked, avenging young adult writer by night, which is perhaps the best intro bio line, one of the best that I've heard. After getting her MD, she did her residency at Stanford, where she met the intersex patient who inspired her debut novel, None of the Above, which was a Lambda Literary finalist, a Publishers Weekly Flying Start, an ABC Children's Group Best Book for Young Readers, and an American Library Association Rainbow List selection. Her next novel, This Is My Brain in Love, was named an Amazon Best Young Adult Book of April 2020 and a 2020 NEIBA Windows and Mirrors book. She is proud to be a board member of Interact, Advocates for Intersex Youth, and is a founding member of We Need Diverse Books. Her essays have been published in Newsweek, The Washington Post, The San Francisco Chronicle, The Philadelphia Inquirer, and Scientific American, among others. So with that, I am going to, Ilene, allow you to share your screen.
Great. See if this works. Oh, no, wait, it just said I'm disabled.
Let's see.
Try again. Thank you for everybody who just stopped, Jubilee and Georgianne and Ria. I hope you guys, actually, I hope some people stay on because I would love to have you guys involved in the my post presentation talk as well, because
around.
Hopefully I won't go over
in the background, but I'll be
there it goes. Looking good.
Ilene, are you able to share? Or
I'm just
okay.
Deciding which part of my screen to share. There we go. I don't know if you guys can see that. I just figured out how to do this today. It took some Googling, but it's very exciting to me to be able to cheat while I'm doing this. So, so my presentation is briefly titled, Has Medicine Failed the Intersex Community? But it's also just a general overview about the care of the intersex patient, past, present, and future. And before I really started, I know that a couple of the attendees are physicians, but or in the medical profession, and I just wanted to make sure I wasn't I was meeting their needs, because I do think that, as this panel shows, there's just a lot of work to be done within the medical community to make our office spaces, our public spaces, our emotional spaces available for intersex patients. I think I asked in the chat room for people to raise their hands, but if this gets boring for anyone who's not a doctor, please tell me and I will shift gears as appropriate. So without further ado, thank you to everyone for having me here. Intersex care is really something that I think is really poorly covered in most medical school curriculum, including my own. I would say that on average, probably medical schools spend maybe 15 minutes of their first 2 years of education on intersex cases. I happen to be lucky in that I actually got my best education from an actual intersex patient who really exposed to me the gaps in care. I was a resident at the time, and a urology resident, and I was involved in a surgery to remove someone's gonads. My attending doctor had supposedly spoken with the patient beforehand, supposedly gained consent, but when I saw the patient post-operatively, it became clear to me that that teenager had no idea what was going on with her body, and it was one of the most eye-opening experiences of my life, to feel really utterly betrayed, to realize that my patient had really been betrayed by the medical field. She and her family had not gotten appropriate informed consent. She had no idea she was going to use hormones. It sort of planted that seed for wanting to learn more about the community, and eventually becoming an advocate when I see how poorly intersex people have been treated. So the objectives of this webinar, because I think it is still CME activity, increase awareness of intersex, obviously, encourage critical thinking and understand the gaps in scientific knowledge. That's one key area in which the doctors of the present and future can really contribute to making intersex lives better. And then finally, implore yourself to put yourself, I'm trying to implore any doctors to put yourself in your intersex patients' shoes. We've already had some great examples of how not to interact with your patients, and I'm going to give you one more. This is from a Facebook forum that I'm part of. A young woman just saw her urologist and told her urologist that she wished that she'd never had the surgery they had as a baby. But the urologist's reply was, Yes, you do. So obviously, this is not the epitome of compassion and empathy, and I think that it speaks really strongly to the very paternalistic viewpoint from which many doctors approach a lot of their patient care. And I'm going to talk in the rest of this presentation about how that paternalism has, damaged countless lives. Because there were a few questions in the beginning about terminology, I just want to briefly go over what intersex is, the biological condition in which people are born with anatomy that's not typically fitting neatly into your understanding of what's male or female, either because of chromosomal sex, internal genitalia, external genitalia. Some of the syndromes that fall under this umbrella, because it is a big umbrella term, Bria and Jubilee have CAH, or congenital adrenal hyperplasia. Durjan and Alicia have CAIS, or complete androgen insensitivity syndrome. But there are a wide range of syndromes that fall in this category, some that we don't even know about. Quickly, this is just sort of a thing to say that intersex does not mean transgender, but infants who are assigned the wrong sex at birth may identify as transgender later on in life. And most importantly, the term hermaphrodite, do not use it. It's considered a slur by many, although, as you can see from the previous slide, it's a term that was actually used in the medical textbooks I still have upstairs. In 2000, the medical community and some activists came together, and they actually tried to change, the language surrounding intersex a bit, and coined the term disorder of sex differentiation. But that also is falling in less favor, because what teenage girl wants to have a disorder of sex differentiation? Again, that word disorder pathologizes, intersex conditions, when in fact they're just differences. And I would say that many people with intersex experience still prefer the term intersex, though there has been some conservative pushback, particularly within the CAH community, where many of them do not like the attribution, probably possibly because they do not feel particularly aligned with the LGBT community. But words really matter. It seems like semantics, but nomenclature makes a difference. There are countless micro traumas that clinicians can perpetrate on people by using terms like inadequate anatomy, or abnormal, or virilized. And indeed, a survey of 150 intersex patients showed that 2 out of 3 had a negative emotional experience related to terminology. And this is really important, because care of intersex patients is really key to an understanding of the ethics of service, access to care, the need to treat a whole patient, and to really try to counteract your ingrained assumptions of gender heteronormativity. So despite probably looking like I'm 16, I'm actually pretty old. I'm in my 40s, and I can even say for myself, I came from a relatively conservative background, and I still struggle sometimes misgendering people, and approaching patients in my practice with assumptions that I know better than to have. In addition, intersex rights really have become human rights because, again, of the paternalism that so many of the doctors in the past have imported upon intersex bodies. It really raises questions of the consent process and about medical legal. And it's also not rare. Intersex traits can happen in as many as 1%, like 1 out of 100 people, although not all people with intersex traits, again, identify as intersex. Again, just to give you an overview of the different types of intersex conditions and their prevalence in the population. And I'm happy to share these slides with anybody if I'm moving too fast, because I know that as Alicia says, there's a lot of ground to cover. We've already talked about how I became an activist, and it's really based in the fact that I started reading stories about how intersex patients were treated in the very not too distant past, so like within the past 10 or 20 years. Diagnoses were concealed. Intersex people were finding out because of biology classes or TV shows. They found out they were intersex by reading their medical records like decades after the fact. Children were subject to repeated genital exams, parades of residents. If you can imagine being a child and having multiple people coming in for genital exams, medical photography. As we discussed, genitals are often surgically assigned at infancy in the past, and gonads were typically removed because patients were told that they would become cancerous, whereas in fact, malignancy rates range from as high as 60%, but to as low as 1% in some conditions, whereas prostate cancer autopsy rates are 15 to 30%. And breast cancer is incredibly prevalent, but you don't go lopping off people's breasts, when they're children, to prevent breast cancer. Here's a great example of someone who found out that she was intersex because she was doing a buccal smear in like biology class to sort of determine their chromosomal makeup, their sex chromosome makeup, and she was shocked to have B46XY, and that's how they discovered this when she was in college. Again, surgery has a really checkered history, but for people who are unaware, the types of surgeries that were inflicted upon intersex children included things like the reduction of an enlarged clitoris because it was thought to be too masculine for a supposed female body, gonadectomy, vaginoplasty. A lot of kids with CAH have something called a urogenital sinus, where they actually lack a vaginal canal, and so people would do surgeries, sometimes involving bowel, to create a vagina, again, as Bria discussed, with the assumption that they are going to have penetrative intercourse. And hypospadias and epispadias repair is a bit more controversial, but many people with really severe hypospadias and who've gone through multiple surgeries do identify themselves as intersex because of the intersex-related trauma due to their conditions. All of these surgeries were done, are almost uniformly are done not for true medical necessity, not because they're life-saving, but because they're to normalize sex organs. Many of you guys know that there's a transgender healthcare crisis because transgendered patients, like intersex patients, always have to educate their providers. They postpone treatment, they delay preventative care, and the same exact thing happens within the intersex community, whereas 80% of people have changed their care, they've stopped going to specialist care, and I know this firsthand from my friends who just struggle, as Julie was saying, to get hormones. And the saddest thing to me is that so many intersex children are operated on at youth, and they often do have access to very particular clinics in university settings usually. But then when they grow up and they leave the care of their pediatrician, they lose access to care almost completely because very few adult internal medicine people or urologists know how to take care of it. It's what's called transitional care. And more patients than I can count have been told there's nothing more that they can do for their chronic pain, for their anorgasmia, for their urinary incontinence. And there's a sense of hopelessness within the community that shakes me to this very day. So as a doctor, and I'm speaking to the medical professionals out there, what can we do to regain the trust of your intersex patients? And there are lots of different levels to this, right? Because there's a personal level, whereas every doctor has the power to reduce shame and stigma by reducing like the very active medical gaze, thinking of your patients as people, reducing the use of teaching moments, particularly in academic centers. And you can also educate your office staff so that they know that not all females need to be asked for pregnancy tests or when their last menstrual period was. It can just say, do you menstruate? Their endocrine clinics, similarly, I think it was Georgianne who told me that their endocrinologist's office said that they don't give hormones to people who are transitioning. Obviously, I think the biggest barrier to access to care is just that medicine is so truly over-specialized, and care is really fragmented. Like a urologist doesn't necessarily speak to an endocrinologist who doesn't speak to a psychiatrist, which is why multidisciplinary clinics are key, but they're hard. They're really hard to put together. And so, but as the best people, the best doctors know that no one doctor can provide all the answers when it comes to intersex care. Surgery is, of course, the white elephant in the room, and I feel a little bit bad for a lot of my pediatric urologist friends because many of them do have good intentions, because many of them come from an environment and from a learning experience where, where unclear gender assignment was considered a social emergency. I remember very clearly one of my attendings say, like, giving us one of those quizzes that they give people verbally. So what are the two true pediatric urology emergencies? One is torsion, the other one is intersex, because it's considered a social emergency. But in doing so, they play on the parental fear of ambiguous genitalia, and they're really relying on a lot of outdated research. Here's a graph of the malignancy risk for certain gonads, and as you can see, there are some that are high, where that you can legitimately say, you know, if you can flip a coin that something's going to be malignant, maybe you might want to take that out sooner rather than later. But when it comes to CAIS, or androgen sensitivity syndrome, those rates are so low, putting people at risk for osteoporosis, for hormonal imbalances, depression. It's painful. The people who are really pro-surgery say that doing so reduces parental embarrassment and anxiety. Again, why are you inflicting that upon a child? They do suggest that infant surgery may be less technically challenging, although you can counter that with the more advanced techniques in transgender surgery. This paradigm is really shifting because they're showing that these surgeries, you know, surgeries involving genitalia can be performed for older people. And there's the possible benefits to intervening before memory of the surgery persists. I mean, some people say that, you know, some parents don't like the idea of their kids growing up having had this trauma of surgery. The cons, of course, are that pretty much all of these surgeries are irreversible. There's no way to put Humpty Dumpty back together again. There are risks of pediatric anesthesia that are becoming more and more apparent. It can cause behavioral and cognitive issues. And most importantly, if you assign someone a gender, if you surgically assign someone a gender that they don't identify with when they grow up, it's catastrophic. And there's a potential for chronic pain, lasting adverse effects. And overall, the outcomes of genital surgery are extremely poor. I mean, it's hard to know 100% what everyone's picture is because the quality of the data is really poor. But in general, there are statistics showing that 36 to 80% have either problems including stenosis after or closure of the canal after vaginoplasty, problems with body image, like that they were assigned the wrong gender, felt like they were dissatisfied with their sexual function, and also that they have pain with intercourse. Again, bad news here. 80% rate of non-sensuality in people who undergo certain surgeries versus 20% of the control group, whereas a significantly high rate of anorgasmia. Some people would say that these involve outdated surgeries, so-called surgeries that didn't spare nerves. And this was a study that was conducted 20 years ago, but no one has ever produced a study showing that the newer techniques actually have better results. I would say that the best thing to happen with the intersex community is the invention of the internet and the movement that people like Interact have created to bring all of this history into the light. And I highly encourage you to look at the Washington Post magazine's cover story on intersex surgeries and listen to the stories. I mean, if there's anything that I would ask of any medical professionals, just take the time to listen to people's stories. I know that as doctors we're taught that data is king, but I mean, something as difficult to study as intersex, where it's relatively rare and there's enough stigma that people aren't necessarily all willing to talk about it, and care patterns are drastically different from region to region. You really have to rely on these anecdotes because they give us key information on how the failures of our past can be corrected. Clitoroplasty is something that emphasizes like cosmesis, right? How it looks over sexual function. Vaginal surgery, as we said, makes the assumption that children are going to ultimately desire penetrative intercourse. All these people are subject to doctor assumptions of gender heteronormativity, whereas in fact, for many conditions, including CAH, there's a lot of a gray area in, you can't say not all of them, not all of these children are going to be binary. And how can you subject them to irreversible surgeries when you don't even know what gender they're going to identify with? So things are changing, very, very slowly. The most recent consensus statements, suggest that people proceed with caution but there's still no agreement, and there still are bad actors out there. There are surgery centers that continue to do these procedures. And the people who are pro-surgery argue that there's, quote, not enough evidence to support non-surgical interventions. And they suggest that, you know, the social emotional harm that kids can have growing up as intersex is enough to justify surgery. But again, people like me who are advocates against surgery argue that that doctors should do no harm, and that you shouldn't treat a psychological problem with a surgical solution. And isn't the burden of truth lying on the irreversible procedure? If there's no data, shouldn't you not do the thing that's potentially harmful? And there is more data coming from France showing that deferring surgical treatment results in is acceptable both for patients and families. And again, that's the whole point, right? Is to have the patients and families be comfortable with their diagnoses. And again, more and more of my colleagues, particularly in Europe, actually, are very clearly saying that surgical procedures can need to be curtailed a bit, and that the indications for surgery should always be restrictive. And that's pretty great, a 90% consensus on this in Europe. The sad thing is that there's still 9% of doctors who would very likely proceed with many of these surgeries. So for any of you who are in the medical profession who do want to find out what research they can do, who are in their early years when they are trying to determine what to do with their careers, I would argue that there are very few areas out there that are as underserved by the research population in the intersex community, and that's a really great career opening, because understanding the impact of these genital surgeries, it's something that is just really poorly understood. Like, the studies are underpowered, they don't have as many patients, the data sets are like all over the place with different surgical techniques, and again, they don't focus on the outcomes that the intersex community cares about. And even surgeons admit they don't have the problems. I mean, this is from a study 13 years ago on pathology reports from the so-called nerve-sparing procedure, but they admit in their conclusion that they don't know what the sexual function is. But this is 13 years later, and these are procedures that were done in the 90s. They should have long-term data on this, and it should be exposed to the light. And as a doctor, and people ask me all the time, how can you, as a parent, would you ever do this? And I always say no, because I don't think there will ever be enough data for parents to make a truly informed decision for their children. I mean, as a urologist, I speak very frequently to adults who are fully functioning, fully formed, know their gender identity, know what they understand their own risk profile and their aversion to risk. And I monthly have conversations with people who are unwilling to even just do a biopsy because there's like a 1% rate of sepsis. And so, patients should be allowed to make decisions over their own bodies, and I never begrudge men who defer a biopsy. But all I can do is inform them of the risks. And when you don't have the data to inform someone of the risks, it seems unethical to proceed with that procedure. For instance, this is some of the best data there is out there on intersex surgery. It's 11 sites and 5 different symptoms, and there are only 27 people involved in this study. 27. There was no control group. It's a prospective observational study, whereas this prostate cancer study that I always quote people to, it was a double-blinded, randomized controlled trial of 18,000 people. Compare that data to this and expect people to make decisions about their children's genitalia. It's hard for me to believe that any doctor can confidently suggest can comfortably and ethically recommend surgery. The results of surgery, as I said, they are replete with complications. Anywhere from 1 in 4 to 1 in 10 can have different types of complications, particularly hypospadias with surgery, where complications rates are up to 50%. Again, more data, more sad statistics on how many people lost a follow-up, how many people have complications. 1 in 4 have complications within 6 months. And most importantly, a lot of people suggest that these vaginal surgeries have to be done to prevent UTIs. In fact, their own studies show that people who have surgery are actually more likely to have urinary tract infections than the people who are able to escape surgery. And as I said, can pediatric consent truly be informed? And obviously, any parent has to make a decision for their child, and it's difficult. But when you talk about all these medical issues and psychosocial issues, it's always better to hold on the brakes. And studies have shown that parents who do decide to proceed with these surgeries, they have very high levels of decisional regret, up to 1 in 4 and possibly higher, because this hasn't been researched. And many of these rates might be underestimated because these are parents who were surveyed a year after their child's diagnosis and surgery, and so they were asked to comment on their kids' satisfaction rate when they were still infants. Who knows what the decisional regret is when children are older. As Georgianne kind of mentioned, parental decisions are really, really dependent on who's getting the consent and on the type of language they use. There are focus groups that show a medicalized and demedicalized consent process, and there was like 2 to 1, the people who watched the medicalized video were more often, like 60% of them chose surgery, whereas only 23% did in the demedicalized group. And the demedicalized approach is an approach that approaches DSD as a dynamic disorder, as something something that needs to emphasize resilience and psychiatric care and support. It's sort of like the difference between a fixed mindset and a growth mindset. And many of even the multidisciplinary clinics state that they have poor documentation of discussing critical issues. And this is my favorite slide. This goes back to the fundamental truth of medicine that our words matter. It's not just words. Every single word we utter is going to affect how our intersex patient views themselves and on the care choices that their parents make. And it's important because LGBTQIA youth are more likely to die by suicide, and as I said, more likely to change their care. How am I doing on time? Okay, I'm rushing through this, but that's good. More time to discuss it. And I would say that the vast majority of intersex people I know have medical PTSD due to being treated as objects, who feel unable to say no. I mean, Jubilee, you talked about how you wish that you felt brave enough to be able to talk back to your doctors, and that is not an uncommon experience. And there are invisible complications. Suicidal thoughts are very high, particularly in people who undergo gonadectomies. It's high, similar to adult survivors of child abuse. And whether that's due to either the medical PTSD, but also due to the hormonal challenges that happen because of that, it's completely unknown because it hasn't been studied. At the same time, people who are unoperated on, and I know a couple of intersex friends who are lucky enough to have escaped surgery, they can grow up with gender atypical bodies and do well with family and peer support. So if you are a medical professional that does want to go ahead and treat intersex patients, of course, it's really important to have a multidisciplinary team to educate your staff, to educate your community, and make sure that you have the most supportive informed consent process as well, that one that emphasizes personal autonomy and bodily integrity. I mean, multidisciplinary centers, as I said, they're extremely difficult to put together. I've spoken to people at my home institution, and they say that it's too hard to get funding for psychiatrists. And often when these centers these multidisciplinary groups do collaborate, there's often a power gradient where the surgeon is sort of, at the top, because they often have very forceful personalities, and that can obviously impact care and reduce and increase bias for certain procedures. So any doctor obviously took the Hippocratic oaths, so my rule of thumb is for anything you do, keep calm and do no harm. And most importantly, silence equals death. So this is where any person, whether you be a doctor or anybody, can help combat the stigma and shame of intersex conditions, and that's because advocacy belongs everywhere. In the office, with your patients, with your staff, in your home, talking to your children, saying that not all women have uteruses, not all men have penises. In particular families, some of my most amazing conversations actually have been with some of my husband's 80-year-old grandparents, and talking to them about what my first book is about. And some of them a lot of them are much more open to it than you think. And in the World Wide Web, just sharing an article that Alicia or Georgianne is in. Georgianne can talk about her experience with Dr. Phil, numerous other people. Oprah had a section in Intersex Lives in the past as well. Sharing that type of thing increases awareness, and it's one of the best things that any medical provider can do. Because if we don't help increase intersex awareness, who will? I don't know how much longer. I have a few more slides. This one is particularly interesting because it's, again, an example of how many different doctors, not just urologists or endocrinologists, have to know how to treat intersex patients. So this is something on Facebook from a mom's group that I'm in, from a GYN who had a pregnant patient who had a prenatal ultrasound after an amnio said XY, but they couldn't find the penis. And the stress when you can't find the male penis. And what's so crazy is that this family actually considered termination of this fetus. And in my head, I was like, no, because I know that you can be XY and amnio and not have a penis, because it could be that child has CAIS. And it just blew my mind that people were thinking about terminating because of that. And obviously this OBGYN felt like they didn't have the resources that they need in terms of genetic counseling and psychology to have the parents make a decision. But luckily, the family decided to keep the baby, and they did have a healthy, beautiful CAS baby later on. More importantly, I really just want to encourage all of you guys to keep your eye out for places like Interact Advocates that are just so superb at bringing a face to the syndrome, so that AIS is no longer a question that you're asked for in a board exam. Like specific examples of thriving, flourishing intersex people, so that you can tell people, intersex parents, you can tell future parents of intersex children that don't worry, the kid's going to be okay. These are, amazing people who are going to be doing amazing things. That's their big formal website with a bunch of brochures. They have great what we wish our doctors knew brochures, what we wish our parents knew, and what our friends knew. As Georgianne was saying, community-based collaborative research really is the gold standard. Reach out to Interact Advocates, reach out to the AIS DSD support group, because if you are conducting any studies or surveys, your research will be incomplete if you don't involve the community early on in the design of your experiment or your study, so that you know that you're studying what they need you to study. And science has to be particularly objective because, the world around intersex care has become increasingly politicized, somewhat for the better, because the publicity surrounding certain legislation to stop intersex surgeries has gotten a lot of attention, but both positive and negative. I was involved in a resolution that passed within a bill that was stalled in the California State Senate, where the Judiciary Chair and the committee received like a $50,000 donation by the California Medical Society, which strongly opposed the bill, strongly opposed legislative support and protection for intersex patients, saying that it stepped on their toes as medical professionals. It was pretty sad, as were the words of the Society of Pediatric Urologists, who labeled intersex advocates as militant LGBT activists who want children to be happy to who they are, and who brand legislation as anti-choice, whereas in fact we are very pro-choice. We are very pro-choice for the child. We believe that a child should be able to choose what gender and what genitalia they have. Despite all these barriers, though, change is happening, and you guys are the change. Most recently this summer, we had the most amazing statement made by Lurie Children's Hospital, who stated that they would put a pause on intersex surgeries, largely because of the efforts of intersex advocates like Pigeon Pagonis and community members, doctors like Ellie Kim, who is a adolescent doctor at Lurie. And so I don't, this is more about design bias. And again, I'm not sure how many of you guys are researchers, so I don't want to belabor this. And I just want to, again, point you guys towards not only Interact, but the AIS DSC support group, which is more of a community, perhaps not necessarily focused on activism and more on support. They do a lot of CME, and most importantly, they connect people. And so they're getting it rebranded as Interconnect, and they have conferences and they have chat boards, and they are proof positive that peer support is the most important treatment option available for intersex people. Because the best medicine, I think, really is community. So thank you so much. I hope that wasn't too fast. And again, I'm happy to send out my slides and answer any more questions that you guys might have.
Thank you so much, Ilene. I think that was, that was a perfect pace. We definitely have some requests for your slides, so I'll send you an email with that later. I think that was really, really helpful, and something that strikes me as a physician is that I too have heard a lot of, what you described in medical school, just learning a little nugget about how, this is just, something that needs to be immediately corrected, and then you move on, and there's just not this awareness of how much ignorance there is in those statements, and the backlash to a lot of the things that you're talking about, and just not recognizing that the patients themselves and the people who we're trying to care for are not really involved in those conversations. So just very, very eye-opening, and thank you for laying out all of the research that you did as well, and the need for more. So we're creating a list of these resources. There was a question that came up in the chat that I'll ask from Courtney. So Courtney says, same experience as Jubilee, not feeling like I was empowered to speak up. Actually, maybe I'll just invite Courtney. I can either read it, or Courtney, just interrupt
Courtney,
me if you'd like to ask the question yourself.
I can see it, but Courtney, you can unmute and then we can chat about this. So
yeah,
absolutely. I mean, so how can you give feedback to your doctor? And that's really, and obviously the art of giving feedback is something that takes a lot of practice. And the thing that I've realized is that you can often use a sandwich method, by saying, I know that you really care about, how you're going to treat me. That might be an assumption, but you can at least say it. And then ask your question. But then you can say, but to be honest, this is how I feel. In terms of providing, I think that it can be really hard, because you don't want that interaction to impact your future care. And so sometimes in those cases, it is something that you have to be really careful about, but you can get empathy, I think, by showing empathy, if you know what I mean. You can say things like, I know this is a really unusual thing, and that you might not necessarily have been taught you know, you might not necessarily have been taught as much in medical school, and I know that there's not a lot of data out there, but this is, you know, and often you could even say, I know that statistically most intersex and trans people have to educate their providers, and you can give them permission to be ignorant, if you know what I mean. And then you can say, but this is what I've been hearing from my community, and I didn't know if you wanted me to connect you with someone in my community who might be able to provide you with resources. Because I mean, trust me, medical education is at warp speed. Anything that we're doing in the clinic right now is about 10 years outdated, because like the things that people are discovering in academic centers don't necessarily get filtered down. Like there's this huge lag between actual understanding and care practices. And I want to empower anyone out there who's intersex to know that, and to I guess have empathy for your providers, and that they might not necessarily know what to do, but go and empower yourself with that knowledge, because most patients know more about their syndrome, that end up knowing more about their syndrome, especially if it's a really long-term thing, than their providers do. And that's nothing that a good provider should be ashamed of, because that collaborative care, treating patients as individuals, that's something that all doctors should aspire to.
I would offer something as well, as kind of an internist. I would say also, Courtney, that I think making it clear what your questions are to the doctor, like, can you please explain to me the risks and benefits of what you are proposing, so that you can get clear information from them about why they're proposing what they are. And then I think it's totally acceptable to say, can I think about this and do some of my own research? And then if there are, you know, these other resources that Ilene has talked about that kind of spell out what these concerns are, you know, and even kind of literature that I hope we collect over time, and that we're actually making note of all of the studies that you mentioned, Ilene, that we'll be posting on our UT Libraries website. So we'll have kind of a database of things that people can reference. But I think just saying, you know, can I get this information, and then can I think about it and come back with information to share, could be helpful.
Great. Thank you.
Are there any other questions? I'll ask one last one. Ilene, I feel like I'm speaking a lot,
sure.
but this is, I think this is just like a really, really interesting area. What have you found most effective when you have talked to doctors who you feel may not either have the information that you have? What has been your experience with navigating those conversations as a physician?
So I had the interesting experience of actually infiltrating the Society of Pediatric Urology conference a couple of years ago. And I try to do it like in a really friendly, you know, happy fashion. Like, you know, I have friends who are pediatric urologists, and like I try to introduce through some of those friends, and you know, and I'm just like, oh, I'm just happy would love to participate and help you guys in creating this sort of clinic. And it's been really hard. It's incredibly polarized this time. And I'll be honest that I'm probably not viewed very favorably in a lot of pediatric urology circles, because I have challenged their dogma, because I have, you know, at the state senate, like they would quote studies, and I'd be like, actually that study's flawed because blank. And I know that I'm not received very well in those circles, but I also know that discomfort is good, particularly, and you know, I'm not afraid to piss people off if I know that might influence the way they treat kids in the future. So I've just learned to accept it.
Well, thank you for doing that work, and hopefully we can support you in that. Sorry, I think I cut you off. Continue.
No, well, someone shouted out for Sean Saifa. Yes, I mentioned Pigeon, but I didn't mention Sean Saifa. Wall, who also really was spearheaded and a vital person for intersex people of color, who were the ones who really put constant pressure on Lurie. I mean, and it's sad that they were really compelled to do that position, not because they thought that it was the ethically right thing to do, but because they felt public relations pressure. It's sad because I do know that most of that they hadn't been doing those surgeries for 2 years, but they felt peer pressure from within the pediatric urology community to not, throw their colleagues under the bus. But, Lori was actually one of the good guys. I will attest to that. And I know that there are some really wonderful, compassionate physicians there. I have referred people to their clinic. But because the pediatric urology community as a monolith has really, been like that to any legislation or limitation on their practice, unfortunately, they were put in that situation. And again, I don't want to be an apologist either for my colleagues, but it's certainly a very fraught, complicated subject.
Keep the questions coming or put them in the chat. I have one last one, even though I said my last one was last.
Okay.
You mentioned in your bio and in the title of your talk, this emphasis on literature and how that might shape the response. Could you speak to that a little bit?
I mean, so in practice, like in my practice, maybe I've seen 4 or 5 intersex patients because I'm an adult urologist. I don't work in an academic medical center. So I don't feel like in my practice, I necessarily impact a lot of intersex lives, but I do know that my book, selling 20,000 copies, it impacted many intersex lives because there are that many more people out there who know that you can be intersex and still, that the girl next door could be intersex and you wouldn't know it. And that hopefully when their parents, if they were in that situation where their chromosomes were discordant with their ultrasound, their first thought would not be to terminate. And so that's certainly I think that the capacity for literature, for media, and Interact has done an amazing thing. It has done amazing things with, for instance, the Faking It, the MTV show that had an intersex main character. They've done so much to raise intersex awareness in the population, to tell intersex stories, because the intersex stories are what are going to change the world, because they're the ones that are going to change not only the doctors, but the parents, the friends, the future partners of intersex people, to erase this shame and stigma.
Somebody asked the name of your book. I put None of the Above, and then
Yes.
This Is My Brain in Love. Are those the two?
Yep, and my pen name is I.W. Gregorio. And I'll admit, gosh, that book is like 6 years old now, and it's totally outdated. Like, there's so many things I would do differently because I really became really entrenched in the intersex community while I was writing it. Maybe there'll be a second edition sometime soon where I can. And I did shout out to Pigeon and Shan Sci-Fi in the acknowledgments. So, and my friends at Interact. I mean, it's in many ways, I feel like those stories, having today's teenagers grow up with those stories, I'm hoping that, as they say, the tide of progress moves ever forward.
Well, thank you again so much for your time, and thank you to everybody who participated in the talk. We will send out a reminder for talks. We have another talk on Friday, and then the recording of this talk will be posted on our UT Libraries webpage, and we'll send out a link to that.
Thanks everybody
for
coming.
Bye.